All right, everybody, Mother's Day is around the corner, and while we celebrate moms and babies every day in our job, we want to do something special to celebrate you at home. So we're going to be doing a giveaway for an Amazon gift card.
We're thrilled that you're here, that you found us, and that you take the time out of your day to listen to our podcasts. It really says a lot about the mom that you are, the mom that you want to be. And we're going to celebrate you with, as she said, the Amazon gift card, $20. So what we'd like for you to do is to go onto one of our platforms, smash that little button that says follow or subscribe. And then if you'll go into the comments and just comment Mother's Day.
Mother's Day.
We will look at all those comments. We will put the names into a randomizer app on the computer and let it just select one. Then we'll come back and reach out to the winner. And so just go ahead and give us a like and a follow. Share it with your other mom friends. We would really appreciate that. We'll do our drawing on May 9th and we'll reach out to you then.
Yes.
Good luck. And
you're doing a great job. Go heat up your coffee.
Yes. Keep being awesome.
The information in this podcast is for entertainment purposes only. Consult your healthcare provider for proper care regarding your specific situation.
Welcome to Rattled Nurses, the podcast that's here to shake things up when it comes to pregnancy, breastfeeding, and postpartum care. Hosted by two experienced nurses, we're bringing you real talk, expert advice, and a whole lot of laughs as we navigate the wild world of newborn care.
Whether you're a first-time parent or adding another little one to the mix, we've got the tips, stories, and answers you need to make this journey a little easier and a lot more fun. So grab your coffee, even if it's cold, get comfy, and let's dive in.
To Rattled Nurses. So happy you're here with us. So we have a guest speaker. This is Jackie. She is our lactation, her certified IBCLC lactation consultant. So we'll have her tell us a little bit about herself in just a moment. But first we're going to do our jokes and our name cards. You ready?
I'm ready.
Okay. So I do have to tell my joke. We have a new employee, and I made her write a joke on the board. And the joke that sarcasm and sunshine board. And the joke that she wrote, she goes, how much money does a skunk have? 1 cent.
Oh, my gosh.
Cent. S-C-E-N-T.
Yes.
Just 1 cent.
1 cent.
Okay.
1 awful cent.
Do you have any jokes?
I do, actually.
I'm so excited.
So you see my earrings? I wear them just for the occasion. I love me a good rainbow.
Yep.
But do you know where bad rainbows go?
Bad rainbow.
I do.
You do?
I do.
Where?
They go to Prism. It's a light sentence.
But they have time to reflect.
Yeah.
I'm so stoked.
That's good.
I really didn't know if I should have waited and just let you tell the punchline, but I'm like, I know this one.
We are so in sync, always.
I know, it's funny. Okay, now we have
weird.
So we have our name cards that are things that would be names that would be great names if they weren't actually things. And so I have a couple of mine, but Delana also has some. So this is our blind react of names that would be nice if they weren't actually things. Okay. I have,
Edge.
This is actually masculine. Edge.
Oh, very much so.
I think I've actually had a couple of these, but...
have you?
I think I've had an edge or two. Stop it.
But not 4, no square.
All right, there's edge.
Okay.
Edgy.
I'm next, huh?
Yes.
Okay.
Trellis.
That's a good one.
That is a good one.
Isn't it good?
Yeah.
I thought it was
there could be lots of nicknames for trellis. Be like Trelly, Ellis, Ellie.
Ellie.
It could be male or female.
Yes.
Masculine
It
or
could.
feminine.
It could.
I do like trellis. That's a good one.
I think it's good. I lean more toward feminine because I think of ivies
Yes,
and roses.
that's
and
true.
Yeah.
What if you had an ivy and then a rose and then you had a boy? You could name it trellis.
Oh, that's
that's
actually
true.
kind of cool.
That's true.
I would be like,
Way to fit a boy.
y'all,
into
there's this name.
If the
You have to
last
hear
name
it.
was Bush, Ivy Bush, Rose Bush.
Okay, now, my
Okay.
grandma actually knew somebody. She's been long since gone, I'm sure. But her name was Ima Rose, her first and middle name, and she married a Bush.
I'm a rose bush.
I'm a Rose Bush.
I kind of love it.
I'm not sure if it was an upgrade or a downgrade.
I
when
don't
she got
know
married.
either, but
I
it's
think I'd
kinda
rather
funny.
be a Rose.
Oh,
I did
I'm
know
a
there were
Bush.
I do know there were some women.
I'm a Bush.
Yeah. There were some children named in, I think it was in Texas, where one daughter was named Ima and the other one's Ura. So you could have put anything with that. Just about anything.
The things people do with names. Okay,
So funny.
I have another one. Oh,
Placenta.
No.
okay. If it
no.
didn't have a thing, if it wasn't actually a thing,
Okay.
think of how it rolls off your tongue. Placenta. Pla- Placenta. Say it out loud. Come here, placenta.
Placenta.
It doesn't sound that bad. It's almost how anesthesia was.
Lady
Anesthesia.
Placenta.
Lady. Wear the crown, Lady Placenta. Okay.
Oh, goodness. Okay.
Those are mine too.
Okay. Let's see. Where am I going to go next? Oh, here we go. This is fairly close to one you've had before.
I think I had that before, but mahogany.
Mahogany. Yes.
I actually do like that.
Well, you know,
Like it.
we
Mahogany.
could really put a different swing on it and throw an apostrophe in there like my name. It could be M apostrophe
Mahogany.
mahogany.
Or it could be like you could change the spelling on the last part. Neigh. Mahogany. Mahogany.
Yes. Yes. So
That's
funny.
How about hollandaise?
That's a good one.
Oh, yeah. There
Look at you right off the cuff.
Good name her.
Hollandaise.
Call her Holly.
Holly.
It kind of sounds like the name of
Daisy.
a rock band or something to me.
I like it.
I'm kind of hungry. Put that on everything. A little saucy.
A little spicy.
Totally rock band. Hollandaise and the
Hollandaise.
sauce.
We don't tell what the sauce is, but it's there.
It's a secret.
It is a secret.
Hollandaise and the secret sauce.
And the secret sauce.
I like that even better.
All right. Do you have one more? Or are you going to save them?
Let's
do one more.
Okay.
I wanna
okay.
do one more.
Let me see. Which one do I want to go with? Oh, here we go.
Nylon. Nylon.
Yes.
Okay. Come here, Nylon. Nylon, it's time for your nap.
Definitely a little more masculine.
Yeah, I think male too.
Nylon.
Nylon.
I'm just waiting until we see it.
Now we have another. We should do like a vinyl. Nylon, vinyl, polyester.
Yes, exactly.
Okay. Okay, I'm done. Okay. All right. Fans, friends, do you notice our shirts?
Loving the
We have
shirts.
shirts.
I love the new shirts.
So we have to brag about our shirts, how cute they are. And now we're going to look for merch. We're going to have merchandise at some point. So if you have something in particular that you're like, that's a great idea, we should make that with the logo on it, let us know. We might do that. All right, Jackie, our amazing IBCLC. All right, tell us about yourself. How many years? All the things.
Oh,
When did you get your cert?
I've been a nurse since 1996. Always worked with moms and babies. Level 2 NICU babies for most of my career, about 10 years in California. And then in the great state of Texas since then, since 2006. I've worked mom-baby. Most of the things have always been where I fall back on really liking helping moms with latching their babies, helping them accomplish a latch that's comfortable and effective, And I was really surprised at how hard that is for
Yeah.
a lot of people. I think most people think you're just going to put a baby up there and it's going to breastfeed.
Yep, that's what I was going to talk about too. Tell us what IBCLC is.
It stands for International Board Certified Lactation Consultant.
And it's
So it's where you have a knowledge base where you actually share the same information all around the world.
so if you have a lactation consultant like that, as it is IBCLC certified, they have to take their own set of boards. These are boards that like Delana and I don't have to take. They have to take their own board test.
It's intense.
It's an intense certification. So they know what they're doing. So we brought on Jackie because we do want to address, this is obviously going to be a breastfeeding episode. This one, we might make 2 episodes out of this, just depending. But we brought on a lactation consultant because it's very difficult. It's not as easy as other people make it seem. I even had a patient the other day who was in such distress. She was having a lot of difficulty, and she had told me, she was like, they make it seem so easy in the movies. That is legit word for word what she said to me. And I had to be like, no, it's not. Like, it may be easy later on. It may be easy but it is a learning process. It is. So it takes a lot of commitment and it takes a lot of effort. For some moms and babies, it is as easy as put the baby on. But a lot of moms and babies in our experience, it takes a lot of effort. So we're going to talk about some things you can do prior to having your baby. We're going to talk about some realistic expectations, things that you look for, things like that. Okay. So one of the things we want to talk about is what we can do 2 to 3 weeks prior to delivery, before you have your baby or you're anticipating having your baby. What can we do to...
Well, first of all, I would say it's real important to make sure that you talk to your obstetrician. You want to make sure that they feel like you are far enough along in your pregnancy and that things are going well and your baby's well and healthy, because some of the things that you might do to get prepared could also send you into labor.
Yeah.
And so you wouldn't want to put yourself or your baby at risk by doing things prematurely, let's say.
Yeah.
That sends you into labor and your doctor not thinking that it's a good time to do that. But some of the things you can do is just far as stimulation to the breast, to the nipple. Those kind of things can trigger labor, but they also can trigger milk production. So if you are doing just a massage of the breasts or stimulation to the nipples, or if you can take a washcloth and use your washcloth a little bit around your nipple area, a little more than you might would when you're normally taking your shower, to kind of get in that area a little bit less sensitive when the baby starts latching and the tongue is rubbing against that area.
We're toughening it up a little bit.
Yeah, so they're not quite as sensitive, as just starting this and doing this every 2 to 3 hours, 24/7. You've taken a little bit of chance to expose that area to other sensations. Also, the massaging and pumping, if your doctor says that's okay, because that is going to trigger, if we start talking about breastfeeding hormones. One of the major breastfeeding hormones is prolactin.
Yep.
Right? Mm-hmm. And we all know that. And prolactin, when that's triggered to release, is what helps to cause the milk production. And I like to give an example of that, if you can think about how many different scenarios there are of women who maybe breastfeed in some countries with no supplementation, and they're able to breastfeed their children for years. You might also have somebody on the other extreme who has a preterm baby that ends up in the NICU, and what's going to tell her body that baby even lived, if it was born preterm. But we get those women started with the breast pump as soon as we can, right? We know that's how we do it at our hospital. And those things start triggering the release of different hormones. And the one for milk production is prolactin, and as you know, it goes with lactation, and so that'll get started on milk production. So if your OB is okay with that, your obstetrician, maybe starting early on some of that, you might have a small amount collected in case you're not putting out very much. So that's kind of helpful, that you'll have a little bit of extra there to bring it to the hospital if you want, but also just to get your body started producing.
I really like when my moms do that. Like, I've had quite a few lately who will kind of go above and beyond, and they'll start the stimulation process, and they'll have colostrum collected, and like they'll buy the little syringes and bring them to the hospital. I'm like, yeah, excellent. That's wonderful. I can use this either as an appetizer. I can use it to help baby latch on. I can use this as a little dessert. This is perfect. Yeah. So I'm loving that people are starting to do that a little bit more. And, you know, as Jackie just said, make sure it's okay with your obstetrician, because we don't want any complications.
Yeah,
related
too
to
early.
That. Yeah,
we don't want to send
yes.
we don't want to send you into preterm labor and have your baby end up in the NICU. So,
And
we'd like your body to be ready to have that baby. So just get things clarified so we can make sure that you and your baby are both safe.
Yes. Same thing if you're choosing to do like any supplements or like the galactagogues, any things like that, things that will produce milk. Talk to your doctor first, because there are some of those things that do stimulate, you know, cervical dilation, labor, things like that. So be careful with that. Mm-hmm. Okay. So anything to add to that, Elena? Okay.
No, I have started seeing that a lot more, where moms will bring in some syringes with some colostrum. And
I
it's
like
great.
to use everything that I can, especially out of them.
And I think it's so helpful because, you know, I know both of y'all have seen it where babies are born and sometimes they want to go right at it for that first feed.
Yep.
Mm-hmm.
Yes. And sometimes after that first feed, they want to sleep for a really long time.
Yes.
So if you had some of that expressed colostrum, you can still do a little glove,
give them a little
syringe, and give little droplets, and still give the baby a feeding. You know, as we say to the parents, it doesn't matter how the baby gets its food, as long as it gets its food.
Exactly.
And that way, it's still at least it's mom's milk.
Yeah.
Yeah.
Right?
Yep. Actually, that's funny because that's actually one of my follow-throughs for our topics here. Realistic expectations. Our realistic expectations. What are we expecting? Firstly, I was going to mention that babies will come out from the womb, be delivered, C-section, vaginally, whatever, right off their umbilical cord. They're all-they-can-eat buffet. And they'll be raring to go. They'll have a great latch. They'll have a great feed. And then they'll come downstairs to us. And then they won't want to eat
And the moms get so discouraged.
They do.
What's happening?
They get so discouraged.
Right upstairs.
Yeah. So I was going to say that's one of our expectations. Like we tell a lot of people that don't be discouraged if baby wants to sleep for the whole time.
And the other way around. Sometimes they come out and they won't do anything for us right off the bat. They're like, the party's over, all that stress, I'm going back to bed, you know?
Yes.
And so then the nurses even sometimes can get alarmed. They'll bring the mom and baby down from labor and delivery to our department, and they're like, the baby hasn't fed yet. We need to do something. We have to do something, you know? And so, you know, everybody gets concerned because as Sarah was saying, they have their umbilical cord hooked up until they don't. And that's a 24/7 auto feeder. So once they don't, you know, people get a little bit worried about their blood sugar staying stable. They actually a lot of times do very well with what they have still on their stomach. Tides them over. But it can be concerning.
I was going to say there is a fine line, especially from the nursing aspect of when do I get concerned? Should I do any sort of supplementation, whether that's donor milk or if the parents say something else, like when should I do that? Because that is a concern I have. I want the baby to feed and I want the baby to attempt for sure. But sometimes, Jackie, if I can't get them on, like if they don't want to wake up and eat, I want to tell the parents, like, hey, they're not jittery. They're pooping and peeing. Exactly. These are things we're looking for. It's okay. Let's just do some skin to skin, see if they can wake up.
Exactly.
And I don't have a problem with that. But there are some nurses, I'm not going to lie, there are some nurses who will jump my bones if I'm like, hey, we tried to get them to latch, but they're doing their birthday nap right now. They're not having it. They're not having it. Is there anything that we can do to kind of help facilitate getting baby to wake up? I mean, other than...
Well, we can do some different things. You know, I'm not one who likes to get out cold washcloths and rub the baby down to try to stimulate them. But some of the things you can do is, like, you don't want to overwork them. So you don't want to try for 45 minutes to an hour. Because think about it. We're all going to have a lower blood sugar if we're just expending energy and not taking anything in, right?
That's what I tell them too.
So you want to try for, 15 minutes maybe? I mean, of legitimate trying. And if the baby's not going to do it, if the baby's trying, you know, we can continue to work with the baby. But if he's not or she's not, then at that time, like you said, put the baby skin to skin, right?
Let them nap some more.
Let them nap a little bit longer. What's a little bit longer? 45 minutes to an hour. But what you could do even before that is some of that hand expression. And if, like we were saying before, you've been doing some prepping at home, you should easily, or even if you're not, you should be able to hand express some colostrum. The nurses or the lactation consultant can be very helpful with this while you're learning how to hand express, because it's not as easy as just squeezing right at the nipple. There is an actual technique for hand expression. And you can give your baby some of those droplets. The stomach is so small, I'm sure you planned on talking about that in a little bit, but the stomach is so small at first. It's not like what somebody might visualize when they think of giving a baby a bottle. In the very beginning, their stomach is about the size of a shooter marble. So 5 to 7 mLs is adequate for a baby to have, and you could hand express that. And let's even say that if you were to have, I want to go to Outback Steakhouse and have a nice big meal. But somebody else might go and they might just have an appetizer, right?
Yes.
So if the baby's not going to eat at all, and you can't hand express enough for what might be a full meal, you still might give that baby an appetizer. You still might be giving him the snack that tides him over so that everybody feels okay about what the blood sugar level is. And oftentimes, that little snack you give is what gives them a little boost of energy that maybe in about 30 to 45 minutes to an hour, the baby actually will start rooting around. And
you'll see them perk right up a little bit.
Yeah. So sometimes that hand expression is just the energy they need, don't you think?
Yes, and even just smelling, I think that colostrum sometimes will get them going.
Definitely. And I like to teach by that. I'm kind of a goofball. And so when I tell the patients...
We like that.
Yeah, that's me. And so I tell patients, I'm fine if you laugh at me. Or, is that with me? Maybe, both.
It's with you.
Is it?
It is.
But anyway, I like to tell the patients that these babies are my smallest non-English speaking patients, right? So I had to think a long time ago. I mean, now you have all sorts of things that do translation for us so we can speak to people of all different nationalities and who speak different languages. But with babies, they don't know any language. So I talk about our 5 senses and using the other senses that babies might be quick to pick up on, because it's going to take a while before they know what we're saying. But taste and smell, it wouldn't matter whose house you went to and which country. If you like the way something tastes, you like the way it tastes. And you soon would learn that taste is that smell. So if now, you guys both like brownies?
Yeah.
If you came in my house, because you've had brownies probably several times before, and you smelled it, you'd already know that you want it. So I talk about the moms using what they hand express, putting that on their nipple and areola when they're going to start a feeding, even if the baby is rooting around. But because while they're doing that, they're also teaching the baby. So that another time when they're trying to offer it to the baby, it entices the baby to start rooting and be that active partner that she needs in order to get her baby
That's
to
a good one, yeah. I usually tell them to hand express a little bit so we can get baby when we do the nipple to nose, so we can get them to get the smell.
Right.
But yeah, actually putting on the areola to get that initiation smell.
I'll put it on their lips, their tongue, up here, on the nipple, and on the side of the areola that the nose is going to
that they can get that
facing.
smell.
Yes.
They can get in the kitchen, get some dinner.
There you go.
Okay.
That's awesome.
Yeah, that's good. Love it.
So I think that parents should, when they're talking about tummy sizes, I don't know if you're ready to talk about that yet, but they might look at bottles. Look at a bottle and see what an ounce looks like. Because an ounce is 30 mLs. And when we were talking about a little bit ago about the tummy sizes, that's only 5 to 7 mLs. Their stomach size on day 1 is between like 5 to 7 mLs.
And 5 mils is equal to a teaspoon.
Teaspoon.
Yeah, so for
when
reference.
you compare that to an ounce, which somebody might think, oh, my baby needs at least an ounce when they're feeding. We've seen people come in with formulas, and they'll feed them, and they'll overfeed them as far as what they need. So we're not talking about that's all the baby could tolerate or have, but we're talking about what the baby's nutritional need is at that point.
Yeah.
To be able to get in 5 to 7 mLs of colostrum is adequate.
Yeah, and we'll see if we can add this in, but just as she was saying, yes, on day 1, it is about the size of a little shooter marble, like nothing. And then day 3, what is it, cherry tomato? That's what we're using? Okay, cherry tomato. And then even about a week out, it's still not very much. So like a little apricot, maybe 45 mils at most.
Yeah, so
45.
If you're comparing that to that 1 ounce, that first day is 5 to 7 tiny portion of 30.
Yeah.
But even by day 3, it's only like 22 to 27. So you're still just shy of an ounce, even at 3 days.
That's normal progression.
But then we'll start talking about how baby's behavior changes and their hunger changes. Because even though that sounds like a small amount, that's a rapid growth to go from 5 to 7 mLs to by 1 week, 7 days later, they're already needing 1.5 ounces to 2 ounces every feeding, not per day.
Yes. So, and then we start out with that nice thick, honey thick colostrum that's full of all the good stuff.
Yeah.
So then that fills them up and keeps them satiated for a little bit. And then after we do our birthday nap, everyone's exhausted from trying to wake up baby, trying to get baby going. And I think that's one of the things I always am telling people too. I still will see people try to put baby on the breast, fully swaddled, fully clothed. And I'm like, no.
Yeah.
We wake the baby up. We wake the baby up first. Get him naked, get him unswaddled. And I know you've actually taught some of the things
You're asking me that. I'm sorry.
that I teach that. Let me back up because I can't talk today. You have taught some of the patients the things that I'm like going in to teach them too, because they'll be like, oh yeah, Jackie taught me that last night. But one of the things that I often like to do is I'll tell them to get baby nice and unswaddled, wake up, and then get baby to wake up. We kind of change that equilibrium a little bit. We kind of set them on their little behind and kind of give them some gentle rocking back and forth just to get them a little bit more stimulated, get those little eyeballs open. Sometimes that does help wake them up a little bit.
So when you're doing that, I just want to point out you're putting your palm of your hand on their chest and then your thumb and first finger on their jawline or cheek, but not on the throat.
Yeah, we don't
so that
hold
you don't
that.
ever hold around the throat area, so that when you're rocking, you're not putting any pressure on the throat area.
And also you kind of put your hand on the back shoulders here. That way if they
base of
decide
skull.
in the base of the skull, that it gives them some support. They can use their head a little bit more, but it also, we're supporting them on their bony prominences here, not on their soft tissues and their throats.
Exactly.
So, yes, good point.
Good point.
So after we do our birthday naps, and then we go into our nice little cluster feeding phases.
So cluster feeding is another one where then you get the moms coming in or crying or saying, there's something
Yes.
wrong. I don't have enough for my baby. I need to supplement. My baby's hungry all the time. But there's a lot of things that, you need to look at. So sometimes they'll call the lactation consultant in to check on a mom and a feeding with that, because we have to look at what's going on. Is the baby eating frequently but satisfied between their feedings? Then that baby's probably doing well. But if the baby's just not satisfied, not satiated, then we need to be checking that latch, making sure that the baby is getting on a proper latch and actually transferring the milk well. Are we hearing swallows? They'll sound like tiny little clicks. Are we having enough pee and poop diapers? But even if the baby's eating anywhere between like 12 to 16 feedings in a day, whereas first day we're hoping to get at least 8 feedings in a 24-hour period. So that second day can be quite a difference. And moms and dads are exhausted.
Yes.
Parents are exhausted. And so the baby should be able to eat frequently, but they definitely should be eating, transferring well, and able to be relaxed and satiated after a feeding.
Yes. So I do discuss with them. We spend our first day stressing out because we want to wake up and feed the baby, and we tell you we want you to feed about every 2 to 3 hours, at least get that eight feedings in the first day or so. And then the second day, when we can, after we spent that day not being able to wake baby up because baby's exhausted, we spend the second day stressing out because baby wants to be a little booby monster and they want to be on the breast constantly.
Yes.
Yes, I always do preface this with my new moms because I like to tell them, hey, just here are some expectations. This is what I want you to expect. So when this day comes around and when baby does start to cluster feed, it's normal. They are putting in their food order. So that's what I tell them. If they're telling you, that frequent emptying, we want them, we look for those things. We look for pees and poops.
That's a really great point that you just made. They're putting in their food order.
Yep.
Because remember what we said. When they're sucking or you're massaging or you're pumping or you're hand expressing, all of those things are triggering the release of that prolactin. And the prolactin is what says, make the milk. So that's why you could have a 10-pound baby or twins or a 6-pound baby, and your body's going to make a sufficient amount to match what that baby's nutritional needs and demands are. right? So if you've got a baby that's not, maybe you've got a baby that's jaundiced and so he's lethargic, then you might need to do some of those extra things to stimulate your milk production. But just like what Sarah was saying, if you've got a baby who's wanting to eat all the time, he might be getting a small portion while your milk supply is increasing, but he's still getting snacks. And so if you're feeding him frequently, he's still overall getting as much as he should need. But if you are then limiting him or putting pacifiers in their mouth or things like this, then you are going to continue to stay behind as far as making enough milk for your baby. So stimulation equals production.
Perfect. Okay, so now we're going to talk about ways to identify, one of our biggest things to identify a bad latch. And oftentimes, I'll get my babies and my mamas from labor and delivery, and sometimes the damage has already been done. Sometimes they'll try to help get baby on, and they'll be like, oh, yes, this baby's fed wonderful. Sometimes baby doesn't feed wonderful, and I get moms already with blisters, cracks, bleeding. So I want to do the best that I can as their care provider. I want to tell you ways that we can help you identify a bad latch, because what happens when we get a bad latch? We get blisters, we get injuries, things like that. We get bruises, cracks, but also babies don't get their milk. That also yields not transferring the milk appropriately. So, what are your best tips and tricks? What do we look for when we're looking for, hey, that's not a good latch, let's try again?
Well, I'd say that one of the main things I would like to point out to moms is if you haven't breastfed before, it doesn't hurt to get somebody to come and assess the first couple of latches, whether it's your nurse or whether it's as soon as a lactation consultant can make rounds on you. But on your own, because we can't see what's going on the inside, is what does it feel like? If you're just feeling a nice piston-like tug, then the nipple is probably far enough back in the baby's mouth. But if you have a shallow latch, every suck the baby does is going to feel like your nipple is being pinched. Okay, so if you think about it, if we all feel with your tongue the hard palate that you have, and then how far back it takes you to where your tongue finally hits soft palate. So the areola, if you would, on the breast, all of this areola part is great for being milked against the hard palate. But the nipple should make its way back to the soft palate. So it's just getting the tug portion of it.
Yes.
Whereas the areola is getting the milk portion against the roof of the baby's hard palate, and the nipple's just getting the tug. Everything comes together, and then you have all the tiny openings out of the nipple. And that doesn't feel very good if you squish those. It's kind of like if you squished a water hose. The water's not going to flow, right? So you're milking back in here, but then all the openings where those things come together should be able to let the milk flow across, and that's why it needs to be soft palate. So one is, what does it feel like to you? But I'm sure you both have had it where a mom has told you, well, I don't know. I mean, I think it feels okay, or I don't know, it kind of hurts. So another assessment would be, what does your nipple look like right when your baby lets go? You can't wait, can't let the baby fall asleep there.
Yes.
But right when the baby lets go, look at the shape of the nipple. If it looks its same shape, but longer from having been pulled and tugged, that's great. But if now you went from a nipple that's normally round shape to looking kind of oval, or looking like it has a rim on the edge of it, or ridge,
Lipstick.
or
Yes,
the worst
lipstick.
being the end of a tube.
Yeah.
Exactly.
We tell them the lipstick is the no good.
Yeah, it's really not. And so that is a good indicator that the baby wasn't able to get the nipple back to the soft palate. So some of the things you can think about when you are going to is how to do the positioning to get a good latch, and so we'll talk about that too. But just, for assessing whether the latch was not even correct in the first place, those are the good things to check. What does it feel like? Shouldn't feel like pinching. What does it look like? Should look nice and round. Shouldn't look misshaped, the nipple. And then if it is, don't tolerate it. Don't tolerate wrong is my little slogan. I always say eventually
I like
I'm going to have a
that.
t-shirt that says I don't tolerate wrong. But it's all about the breastfeeding, not tolerating wrong, because you're really, one is sometimes women are going, it's okay. It took me a while to get him latched, but it's not okay. You're going to damage yourself.
Yeah, you'll pay for it.
You will pay for it. And it's kind of like, I jokingly say, it's like if you wore the wrong size shoes and they were just half size shoes, but you want those shoes so bad to wear to the prom all night. And they weren't that bad. but you wore those wrong size shoes over all night or hours, then tomorrow, even if we help you by putting your right shoes on, your feet are already damaged. So same thing. If you breastfeed over and over, doing it incorrectly, and then now we come and correct it for you, you're still going to get a correct latch on a damaged nipple. Plus, how much food has your baby missed? So ask for our help. Let your nurses or your lactation consultant help you if you're unsure, and definitely don't tolerate a wrong
Don't
latch.
just endure it. Yeah, don't endure it. We want to help you. Yes,
That's a better word.
You may have not gotten. It may have taken a long time to get baby on. We'll come help you, but
Yes.
break that suction. What I tell a lot of them is break that suction. You're going to go get your nipple back. If you're just pulling baby off because you want to try to latch again, that baby's still sucking. It's just going to pull your entire, we're just pulling your nipple out, and it's just going to hurt. So, of course, break that suction, go in and break the suction, get the nipple, and pull it out gently. That way we're not damaging extra trying to get that baby off. But don't endure the pain. Call us for help. So we got the lipstick shape. We got, so we have sounds too. I tell them, because I'll hear this a lot, the clicking and the slurping and the smacking. No.
Yeah.
Yeah.
Good point. Yeah, if you see their cheeks
Suctioning
Coming
in.
in, yeah.
Yeah. You don't want to latch them while they're crying. When the babies cry, they pull their tongue back like, ah. So you're already starting off behind the 8 ball because, you think about it, you've got to get as much breast tissue in their mouth, the areola, and you're trying to go over a lip, past a gum line, and not just on the tip of the tongue, because the tip of the tongue's just going to be doing that on your nipple, but it's got to be on there enough that the tongue can actually move and pull that back. So if they're crying and their tongue is already back in their mouth, you're going to have a harder time getting it on top of the tongue where the baby can actually manipulate it and pull back.
It seems convenient to try to shove a nipple in their mouth while they're crying, but let's
thing.
just try to get,
How many times have y'all seen a mom who's got a baby latch and she thinks she's going to add some more?
Yes, trying to stuff it in.
Yeah, we're like, okay, well, let's just get to the tip, and then we'll just keep shoving in as we go. No,
Once they've got
work.
that seal, you're not going to be able to add anything.
so yes, take baby off. Try again. Keep trying. Don't just endure that bad latch. So, any other tips for identifying a bad latch? We don't want the pinching, significant pain. We're trying to prevent all that. We're trying to get a comfortable latch. We're trying to protect your nipples. We're trying to get baby to get that milk transfer. Yeah.
That's some of my main ones, like you were talking about, especially if you start forming blisters, blood blisters or clear blisters. Even if your nipple just looks blanched, I don't know if you know what blanching means, but if you were to press on skin and the color kind of goes away, so that's blanching. Is when you've taken the blood out of that area for a brief amount of time. So if a nipple comes out of the mouth, you used to have nice pink nipples, but right for that very brief time, it looks almost like it doesn't have any blood circulation.
We're cutting off the
to
blood
it,
supply.
Then that was not a good thing.
Yes, pinching it off, just like the water hose.
Yeah.
So I usually tell them that too. Like if we're just pinching off the nipple, we're not getting any flow. It's like pinching off a water hose.
Yeah, and I feel like when they're on nice and deep, you typically don't see much of the areola.
Yeah.
When the baby's latched on good, it looks like the babies unhinge their jaws,
Yeah, they
kind of
do.
like a snake when they're on that. That's when you got a nice, beautiful, deep latch.
Yeah,
then.
And it should look like an asymmetrical latch. I mean, if we're starting to talk about a good latch, but
Yeah, which we are, which we are, and those are things I want to do. I'd like to chat about how to get the best latch that you possibly can. Tips and tricks for doing that. It is different for every mom, every baby. Everybody has different breast shape, breast size, nipple size. Baby's got different size mouth. We got shortened frenulums, things like that. So it is a trial and error. We do encourage you to talk to your healthcare provider, your lactation consultant, whoever. But yes, so we're gonna talk about ways to identify a good latch. So
yeah. So we talked about what the nipple should look like when the baby comes off, but we also can talk a little bit about what the position of the baby should be. A lot of people think the baby's mouth should be lined up where they're going to go directly onto the nipple, directly on. But when you really think about it, the nipple should line up at the baby's nose so that when you are holding the baby, and I'll show you how to hold the baby in just a moment, but when you're holding the baby, you're going to press in back here, and you're going to also have your thumb at one side of the ear fingers on the other. If baby's in a side-lying position, it would be like this. But when you're bringing the baby in, the nipple should be aligned to the nose, and you should be teasing the baby. But when your baby goes in, your baby should want that like this. And so I always joke about babies don't have much of a neck. They're kind of like this. So where we would go to eat a hamburger, they kind of go more like this.
They tilt the head up instead of bringing the jaw down.
Yeah. So when the baby does that tilt, that's why you want the nipple up here. So when they tip, they kind of leave that jaw long and open, and they're able to get more of the areola and more onto the tongue. So you're going to be like this, and they're going to go in, and you're going to press fine here, and you're going to get that asymmetrical latch. So where Delana was talking about, you hardly see any of that areola. It's very true, but more so even on the bottom, because that's where all your moving parts are. That's that jaw, that's that tongue, that's everything that does the milking movement. So a latch like this, so the baby has a lot of areola on the tongue and can pull that nipple back.
We've talked about that before. We've talked about that little flange shape when we're all just passing this knit boob around here. But we talked about that little flange shape when sometimes we get the babies with the lips that are tucked in underneath, and then they don't. They're just kind of mushing it around, but they're not getting underneath, and they're not getting that nice little transfer of the moving the milk ducts around. Babies have like a magical way of doing that with their anatomy and their tongue, movement. They massage those ducts out. They have a magical way of doing that. So yes, we do the nipple to nose. We teach them that so that they are not coming down, just like she said. They're not coming down to try to get to the nipple. They're coming up so they can get as much of that tissue in their mouth as possible. Then nipple to nose. We do the belly to belly. We put them so they're not trying to turn their head every which way.
Yes. If y'all would do this, something I try to get the parents to do a lot of times, and y'all could do it with me, and maybe you moms at home could try this. Turn your head towards this shoulder. You do it to this, just so y'all can still see me. But if you turn your head towards your shoulder, and then tip it back like you're going to take a drink, now swallow 2 times.
It's almost
hard.
Almost impossible.
So I try to get the parents to do that so they'll see that I'm not joking, why I'm trying to tell them to turn the baby belly to belly.
Yes.
You want your baby's alignment to be ear, shoulder, hip. So whatever position you're using, whether it's cross cradle, football, or your sideline, the baby should be able to be ear, shoulder, hip, and not having to turn its head like this to drink.
That is a good one. I've not used that. Like I tell them we don't eat our food sideways, but that is
it. Have them do 2 swallows, because I'm not the first one. They're like whatever, but even if the dads are like think they're just going to watch, I say no, or the partner, I say try this, try it. And then because I like the partner to get involved as well, because oftentimes the mom is doing things from the angle where she's at, right? But you think about the partner, they see things from the angle that we are teaching from.
Yes.
Yes.
So oftentimes they see what we see, and they, when we're not in the room, are a good person to have to help kind of politely guide mom if they're seeing that she's doing a little different than what we're showing. Yeah, it really
perfect. Yes. We've actually discussed that in like one of our previous episodes. It's like, what can your support person do to help? And we did discuss that. Learn how to latch and learn how to help. Learn how to nest mom in. Like get those pillows, get those chicken wings up and out of the way. But yeah, help nest mom in, help mom learn, or help your birthing parent learn the good latches and ways that they can help you get the baby and move the baby. So
yes, and I feel like babies certainly, most of the time they'll have a favorite breast,
definitely,
and a favorite position.
Yes.
And so they've all got their own little personality.
Speaking of that, sometimes you'll have the baby where you were talking about favorite breast or favorite position. So sometimes you might have a baby, let's say that's sideline. This baby's coming across, and so the baby's here, and then you go, oh well, I'm going to switch the baby to this other side, and the baby's like,
nope, don't like it.
I don't like laying on my left side.
Discombobulated or something. So that might be a time if you need to switch breasts, is you have the baby in sideline, and then you take the baby straight across.
And do football.
To football. So for the most part, the baby seems or feels, for the most part, like
it's in the same
position. Yes.
Or especially how they were laying in utero. If they were laying a certain way in utero, they don't like to be flip-flopped around much the opposite side.
Yes.
I think I did learn that from you, because I will tell that to my mom sometimes. They're like, well, they like this breast, but they don't like my other one. I'm like, okay, start in a certain, start with a cradle on this side. And then when it's time to go to the other one, just do a nice little transfer.
Yeah.
Just do a nice little slow transfer into football. So we kind of keep them on the same equilibrium without switching them up too much. So
Exactly. And then sometimes there are different positions that babies may prefer or not prefer. I'm not exactly sure why, but some of them, when we go to bring them into the breast, they push back and they seem to resist it.
That arched back.
And they're pretty strong when they're pushing away from
They can get very mad.
And
some of them have their own
not only
temperament.
strong, but then you say, I'm stronger. And then they just get mad and they're not going to do it. So, so sometimes it's good to be able to know a different position and just have your nurse or lactation consultant come and help you with trying a different position. A lot of times side lying is a really, really good one. I don't usually try to teach side lying right off the bat to a mom because depending on what side she's laying on, it makes her difficult to use the arm that's on the side that's closest to the bed. But sometimes it's necessary if I get a baby who's very fussy about being handled and touched and pushed and prodded, so they can lay on that mattress and just be brought in, and a lot of times I can get them to latch. So you just take it one feeding at a time. Just because you need to do this position for this particular feed doesn't mean that's how you have to do it every feeding. So we just take it one feeding at a time.
Yeah, that's why I say it's definitely a trial and error. You don't your first latch on this breast on this position at this angle may not be ideal. So let's switch it up. Let's try something different. I'd also like to point out, every nurse is different. Every lactation consultant is different. So sometimes in our entity, we will get comments like, well, the lactation consultant said something else. Look, it's a different day. That's a different person. We are trying different things. So what may have worked for you today may not work for you tomorrow. So we're going to try something different. We may, something that is kind of controversial, we try to avoid nipple shields. We really do, because I do prefer like that direct latch, like the direct contact. But there are some times where it's warranted. I mean, or if Evie and I have to like get them to start on a nipple shield, get that nipple everted, and then remove the nipple shield and get baby on.
Absolutely.
So there are some times where one LC may say no nipple shields, and then the next one may come on and put on a nipple shield. When that happens, it's not that one LC is doing it incorrectly or wrong. It is more so we're trying different things because we're trying to give you the best emotional or breastfeeding kind of support knowledge base, so that when you go home, you can have this knowledge and these tools, and when no one's there with you except your partner, your support person, that they can help you as well by using the things that we've done. So just keep that in mind as well.
And a lot of times, if you think about it, the more the different ways that someone might show you, you'll find what works for you.
Yeah.
For you and your baby.
Different tools.
And you might use different ones at different times. You might use different ones depending on what location you're at right now. Maybe now you're over at your house and you can lay down and do a side lying in the second bedroom, or you're at your the bus station and you can't do that. And so you're just trying to find a place that you can. So it never hurts to have more information. If it gets to be overwhelming, you can always just tell the lactation consultant or your nurse, what I'm working on right now, or what I've been working on with the lactation consultant, or what I've been working on with my nurse, or what has been working for me so far has been. And sometimes we're trying something different if it's not been working well, wouldn't you say?
Yeah.
So like if you're bringing in a nipple shield, it might be because, the baby's been breastfeeding. Everybody thought the baby was breastfeeding great. But now we're assessing mom, and we're seeing that her nipple is getting little blisters. And or we're getting that second day and we're getting that fussy baby, and we're not having as many pees and poops, or the jaundice level's high, or the weight is too high of a percentage.
Yeah.
It just depends on what factors
so many
going
factors.
on. But that might automatically make us say, wow, we thought baby was doing great. Because we can only go by what we can see on the outside. We can't see what's going on the inside.
We can't do an x-ray on your
And we're
nipples.
counting on you to also listen for those swallows. We're counting on seeing how many pee and poop diapers they have, and are they satisfied with feed. So it's not a matter of just somebody watching and going, yep, she's breastfeeding perfect. So sometimes we're having to do different things because we're having to tweak things. So where we thought the baby was breastfeeding great today, tomorrow, Delana might be the nurse and see that she's got this fussy baby who's now lost 7%, and it's wanting to eat all the time, not just frequently, but staying on. It's upset. It's irritable.
Not satiated.
Right, it's not satiated. And then she comes and she says, Jackie, I don't know what's going on, but this baby's wanting to eat all the time, blah, blah, blah. Here's X, Y, and Z that's contributing to my concern. And we go in and we assess, and yes, the baby's been getting on, but because mom might have really short nipples, maybe this is her first baby is getting on, but it's like this. And it's been just pinching and working away at the nipple in a very shallow amount of areola, not moving the nipple to the back, so it wasn't reaching soft palate, so it wasn't transferring the milk as it could. Maybe I can go in, or one of us can go in and help with the angle and the depth of the latch. But maybe, again, depending on anatomy of the mom or anatomy of baby's oral anatomy, we might need that nipple shield.
Yep.
And so, again, you might be going, well, the other person wasn't using that. Well, we now have a reason that we might introduce that. We want to help that baby be successful at getting and being able to pull that nipple farther back in the mouth.
Yes.
So just try to be open. You're learning, but we're also learning about you and your baby and what it takes to get
And baby's learning too. Baby's learning how to be a human that he or she has never had to do before. So baby's latch one day may be great and not be so great the second day, but it's a learning process.
Yeah. Give yourself grace and give your
Yes.
baby grace. The other thing I like to say about babies is, you're learning, but at least you understand English, and you've also have had many examples in your lifetime that you've had to repeat that demonstration. The baby has neither. The baby doesn't understand what we're saying, and the baby hasn't ever done this before. So you might think, why is my baby not getting it yet? Well, how many opportunities are you going to give your baby to tie their shoes or ride a bicycle or learn how to write their name? And at that point, they're going to understand some of what you're saying. But right now, they don't understand anything.
Right.
And they've never had to repeat a demonstration before. So, again, take it one feeding at a time.
Give yourself grace. That's a good one. I like to also say be kind to yourself. Be kind to yourself, which also should be like a merch thing for us, you guys.
I wasn't very kind to myself on the way over here. I was like so worked up about it.
I know. Well, the first time we did it, we were too. But now we're just talking.
Yeah. Now
And
we're
listen to her. You're such a wealth of knowledge, though.
You are.
It's so wonderful.
It's amazing.
I mean, I didn't know you before you were a lactation nurse, but I have worked with another nurse before while she was obtaining her certification, and the amount I watched her study and what I watched her going through was like so impressive.
It's a lot.
And
It's a lot.
yes.
Yeah. And the amount of continuing education credits, they don't realize that. But what I had to do for my nursing boards versus what I had to do for my lactation boards, it's like you say, it's a lot.
Yeah.
It's a lot. It's a lot more than I actually even ever would use in the short amount of times that I spend with mother and baby in those first few days.
I don't think I clarified also, your IBCLCs are also registered nurses with nursing backgrounds, nursing degrees. So not only did they have to sit for their nursing boards, they had to sit for their lactation boards.
So that's not true of all IBCLCs.
Oh, really?
Yeah, so someone can go and become an IBCLC without having
an RN?
Yes. They wouldn't get hired at a lot of hospitals. Okay, a lot of hospitals are expecting them to also be registered nurses. I can't say all because I don't know what all hospitals do, but most that I know of, yes, they expect you to also be a nurse.
Okay, for our particular entity.
For our entity, yes, they are all registered
RNs.
nurses.
Okay, that makes more sense to me because, I mean, I knew that
That's what we've always known.
That's what we've always known.
Yes.
Our IBCLCs are also
I just
our
didn't want
registered
to
nurses.
downplay an IBCLC.
No, that's
so if
good.
one
No,
of
thank
your-
you.
One of your moms end up
No, that's perfect.
searching out one in the community and then
They still have to take
you're
boards.
not a nurse.
Okay, I gotcha. That makes more sense. Thank you for clarifying that
that's
for
okay.
sure.
That's okay. I just want to throw it out there.
Okay, so we did tips for identifying a bad latch. We did, basic tips for identifying a good latch. A lot of it's a learn on the job situation.
Yeah.
Anything else we want to say before we wrap up?
No, I mean, I would love to show more with the mannequin, but in all honesty, it's just really too hard to be able to manipulate the mannequin baby to do what you would need to do. So I just say, watch videos where you're getting to see some real life breastfeeding. Watch videos on latching. Watch videos on hand expression.
So I was going to
do
say,
a link. Yeah.
so yes, I was going to say in our next one, we can actually just include it in this one. We'd like to talk about hand expression. We talked about the beginning of this one too. Hand expression prior to delivery, if it's okay with your OB-GYN.
Yeah.
But there is a video link that we like to show our patients, and we'll include it in our description as well. But hand expression, it's from the Stanford University, and we use that one. We show our patients, but it has a great demonstration on how to do it. Because it, like she said, it's not just like, pinch it, it comes out. It's like milking honey through a straw. You're trying to get that honey fit colostrum down that straw into the baby's mouth. So, it's a really helpful video. But they also have lots of videos on, breastfeeding. There's also videos on latching, things that we can include for those.
Yeah.
So
this video that she's referring to, I believe, is the one with Dr. Jane Morton.
yes.
So I think Stanford University is one of the routes that we go through to get to that.
Oh, okay.
I don't know that
Okay.
it's like that they, it's not from them or produced by them or anything. Yeah, but it's one of our routes. It's just really easy to get to it because you could go through some other search engines. And if you do that, though, you might find that you're going to come up with so many different ones. And that's fine. Watch however many different ones you want.
Yeah.
That's just one that we particularly like and find very good. The way she teaches it, it's what I learned by Dr. Jane Morton, her technique. Okay. But as Sarah was saying earlier, babies are magical at how much they can remove. So sometimes even when you do hand expression and you only see a few droplets coming out at a time, don't expect that that's all the baby's getting. To add to that, even when you're pumping, pumps are not necessarily that great at getting colostrum out. So when you do,
that's why we do the hand express yes.
after pumping to actually help remove some of those droplets of colostrum, as Sarah was saying, it's very thick and rich, liquid gold. So hand expression is very important to follow when you're doing pumping.
Yeah. Okay. So we will include that link in the description today, and. Yeah, that's about wrapping up for our day here. So thanks for watching. Thanks for listening. Thanks for joining us, Jackie. We love it.
Having me. I really had a good time.
Yes.
Awesome.
All right. So we'll be doing a second part of this, obviously, too. So stay tuned.
More
Congratulations on your baby.
Thank you for listening today. The Rattled Nurses Podcast is not intended to provide medical advice. It is not endorsed by our employer, and we are not speaking on behalf of our employer. Our commentary and stories are our own.
Also, on a serious note, we want you to know that if you are feeling blue or depressed, it is okay. You're not alone, and there is always someone to reach out to. You can call the National Maternal Mental Health Hotline at 1-833-TLC-MAMA, or text the crisis line, text HOME, HOME, to 741-741. Remember, you're doing a great job. Now go warm up your coffee.